Need to start the webinar.
Sorry, where's Liz? Oh.
Okay, good afternoon, everyone. Welcome. Well, good morning, maybe, or good evening. Welcome to our webinar, Improving the Quality of HIV Care Services series from WHO in partnership with the ECHO project. We are happy to have you here today. And we have a wonderful presentation and session that will last about 75 minutes. So I hope you can stay with us for the duration of this session. Next slide, please. So you might already have seen me in the Global HIV Quality of Care Technical Working Group. If you are part of this group, my name is Clarice Pinto. I'm the focal point for differentiated service delivery for HIV treatment under the treatment and care team at WHO headquarters. Also the co-chair of the Global HIV Quality of Care Technical Working Group with is also in this call. This webinar series has as an objective sharing knowledge, disseminate country experiences and best practices. It's a result of the work that we've been doing with the Quality of Care Technical Working Group, and members of the group have contributed to the point where we are able to share these experiences with you, and also have contributed to the development of the Quality of Care Improvement chapter from the HIV Consolidated Guidelines from WHO released this year. Next slide. So today's session is on living well with HIV throughout the life course, palliative care as an essential component of to maximize quality of life. It's a continuation of our last session that was focused on quality of life as well for people living with HIV. And to access that session, you can link connect to the link from the ECHO webpage, and we will also paste it in the chat for you to have access to it. I will now hand over to our colleague from ECHO, Bruce, for the housekeeping. Thank you so much and have a great session.
Thank you, Clarice, and welcome everyone. This is going to be a great session on palliative care. Next slide, please. Just going to run through a few housekeeping items. First, we are offering interpretation in French and Spanish, and you can access the live interpretation by clicking on the interpretation icon at the bottom right of the Zoom toolbar, the little globe symbol. If you want to only hear the interpretation and not hear the original language, you can choose to mute the English or the original language. Next slide. If you have any IT troubles, please chat Echo IT and we'll try to help you out as best we can. We're really looking forward to your questions and comments. So please either put your questions and comments in the chat or raise your hand. You can turn your video on and raise your hand like I am, or you can use the raise hand function just to the left of the Q&A. Actually, I guess since we have that Q&A function, if you've got questions and comments, please put them in the Q&A function. And and we will be monitoring that, and otherwise use the electronic hand raise, and we will call on you and let you ask your question verbally. We will be sharing the presentation slides and a link to the recording on the ECHO website. As Clarice said, we'll share a link to that, to prior recordings, and we'll be sending an email, a follow-up email out, which will include access to all the resources. Next slide, please. We are recording this session, as we've been recording all the sessions in this series, and your attendance is consent to be recorded. Thank you for that. We will be offering a certificate of attendance. That's through the University of New Mexico, where Project ECHO is based. About 15 minutes before the end of the session, we'll share a link in the chat that will take you to a brief survey, feedback survey about how you thought the session went. We really value your feedback. It helps us with quality improvement, and this is a quality improvement series. So please give us your feedback so we can improve the quality of what we're doing and help us plan for future sessions. Just a note about data use, all the data you share with us, we take data stewardship very seriously, and we keep your data confidential. Next slide. With that, I'm going to turn the microphone over to my colleague at WHO, Ajay Rangaraj. Ajay, over to you.
Thanks very much, Bruce. Just going to pull up my slides. Can everybody see my screen? Sounds good. So my name's Ajay Rangaraj. I'm the lead for advanced HIV disease here at WHO HQ. I'm very happy to be part of this webinar today. And really, I'm going to be walking you through the speakers we have today and also walk you through the agenda. So honestly, I have a very small role in this, and we have some really fantastic speakers with us today. So I'll just quickly introduce them one by one. The first is Stephen Connor, PhD, is the Executive Director of the Worldwide Hospice Palliative Care Alliance, which is an alliance of over 375 hospice and palliative care organizations over 100 countries. He's also worked in the hospice palliative care movement since 1975 as an executive, a health services researcher, educator, advocate, and many other roles. And has also been an author editor on books in palliative care. And the next person we have is Professor Richard Harding, is the Herbert Dunhill Professor of Palliative Care and Rehabilitation, Director of the Cicely Saunders Institute, and Vice Dean of the Florence Nightingale Facility of Nursing, Midwifery, and Palliative Care at King's College in London, United Kingdom. And the next speaker we have is Elizabeth Namukwaya, and she is a palliative care physician and a part-time lecturer in the Department of Medicine at Makerere University College of Health Sciences. She's also the clinical head of the palliative care unit, and she holds a master's in medicine and internal medicine from Makerere University and a PhD from the University of Edinburgh. And her current roles include teaching of medical students and postgraduate students, as well as conducts research in palliative care. And she's also a member of the Research and Ethics Committee of Hospice Africa, Uganda, and the Uganda Cancer Institute. And we also have Stephen Watiti with us today. He's a direct stakeholder trustee of the Worldwide Hospice Palliative Care Alliance. Stephen has lived with HIV for nearly 35 years and used and accessed palliative care in the past, and has described his experiences in a book that he recently released called Conquering HIV and AIDS, My Personal Experience of Living with HIV. And I think I'm very happy and very glad to have these distinguished speakers with us today. And I hope that all of those attending can enjoy and benefit from this webinar. And let me quickly walk you through the agenda and the objectives. So firstly, the objectives of this webinar is that we would like to understand the palliative care needs of people living with HIV as part of comprehensive guidelines on ART treatment and care. So this was an important inclusion as part of our consolidated guidelines in HIV, which we released earlier this year. Then the next objective is we would like to understand palliative care clinical interventions and their impact on the life of people living with HIV, their families, as well as their communities. And then share some experiences and examples of programs that have successfully integrated palliative care into comprehensive HIV treatment and care services, both at facility and at community levels. And then disseminate information about models of palliative care and monitoring of quality, and needless to say, answer any of your questions as well. So the agenda, we've already walked through two aspects of the agenda, which is the opening, housekeeping, and the welcome slide that I had. So we have a presentation from Stephen Connor on the global overview of need for palliative care for people living with HIV. And then will be followed by the key concepts of palliative care for PL-HIV from guidelines by Richard Harding. And then we have an example, as I said, from a country program, in this case from Uganda, which Elizabeth will be presenting on. And then we have an overview of the use of metrics to measure healthcare outcomes, palliative care outcomes in people living with HIV by Richard Harding. And then we have a discussion, a facilitated discussion and a Q&A that will be run by Stephen. And I'll be doing a very brief wrap up at the end of it. And with that, I'll hand over. Thank you. And I'll also quickly like to extend a big thank you to the ECHO team, who've been of great support to us.
Well, I think I'll just jump in, if that's okay. I should mention that one of the things not on my CV was that I was the founding executive director of the hospice in San Francisco in 1979 and lived through in the front lines many of the early days of the pandemic. So we're going to talk a little bit about the need for palliative care. We really went through a lot of changes with the advent of antiretroviral therapy, and saw a considerable drop in the need for palliative care and hospice care for people living with HIV. But things have changed in recent times, and so we've really had to take another look, at the need for palliative care. But first, let's have a poll. We'd like to have you take this poll of palliative care for people living with HIV is only about or provided at the end of life. So we have 54% participation. Get your votes in so we can move on to the presentation. All right, so the results appear to be that 96% believe that statement is false, which is correct. Palliative care begins well before the end of life for all diseases, not just HIV. I think we can stop the poll now and share the results. Okay, if we could move on. I'm having trouble with my slides here. Hold on a second. There we go. So this data mainly comes from a publication, a joint publication with the World Health Organization called the Global Atlas of Palliative Care, which is released in its second edition in 2020. And we're using a lot of the methodology we use for determining need. It comes from a special Lancet Commission methodology and report on alleviating the access BIS in palliative care and pain relief. This report helps us identify the need for palliative care based on the presence of serious health-related suffering. We know that over 1 million people a week die on our planet, and of those, close to half need palliative care near the end of life, but many need palliative care before the end of life. In fact, more than half. Most people with palliative care needs have non-communicable diseases, and we're certainly seeing an increase in the incidence of non-communicable disease among people living with HIV. Most people needing palliative care are living in a low and middle income country. Most are older, though that we do have a significant need for palliative care for children. And when we care for someone in palliative care, we always care for their family as well. So we see that only about 12% of the need for palliative care is being met currently globally. As I said, most people needing palliative care are non-decedents, and for HIV, it's the vast majority of people needing palliative care. Almost 90% are people not in the last year of their life, but having significant symptom burden, serious health-related suffering. That's almost 57 million people. Most have non-communicable disease, though we're seeing overlaps. Communicable diseases include not just HIV, but other communicable diseases like TB and some hemorrhagic fevers. These are the adult conditions that are commonly in need of palliative care: cancer, of course, malignancies, dementia, cerebrovascular disease, heart failure, lung disease, liver, kidney, some childhood illnesses. We have included those who've suffered grave injuries and need palliative care, as well as, we said, protein, energy, malnutrition in poor parts of the world, and TB and HIV for adults, over 20% of the need. For children, the situation is similar with these 20 conditions, but also we see an even higher proportion of people living with HIV, almost 30% of the need in children. Again, only almost a quarter living in high-income countries, most in low and middle-income countries. These are adults. For when we look at age and condition, we see in this third bar that for HIV disease, it's more a younger population, 20 to 49, compared to other diagnoses where the age of persons needing palliative care is much older. And when we look at regions of the world, we see this orange bar that over 75% of people needing palliative care in the Afro region are people living with HIV disease. And for children, for similar picture, half of the need for palliative care for children is in the Afro region, smaller numbers in the other regions. So we also look at the decedents, and here we have for adults, HIV disease, primarily severe symptoms, serious symptoms for those who are not in the last year of life, and for children, very similar situation with numbers of children dying and those living with HIV. We talked about the symptom burden and serious health-related suffering, and we have these are the most common 16 symptoms that people with palliative care needs at the end of life particularly have. We have a high symptom burden for people living with HIV: fatigue, anorexia, pain, nausea, vomiting, breathlessness, insomnia, diarrhea being common symptoms, and over 3 billion days of suffering calculated based on these conditions that we saw earlier. And delivery of palliative care quite limited. We have only about 2/3, a little less than 2/3 of countries having no or limited capacity to deliver palliative care, and only about 15% with good integration, the darker colors in the map. And also huge parts of our world, we have a dual crisis with opioids, But the bigger crisis is the lack of access to opioids for people suffering with life-threatening illnesses throughout the world, only available in North America, Western Europe, and Australia, New Zealand. Most of the rest of the world, or 80% of the population of the world, has very severe limits such that it is very difficult to manage pain. I'll end my brief session by just reminding people that last Saturday was World Hospice and Palliative Care Day, and our theme this year was leaving no one behind, equity and access to palliative care. And people living with HIV are certainly among many groups that have inequitable access to palliative care. Thank you very much for your kind attention. We'll carry on now to our next presenter. Richard, I think you're up.
Yes. Thank you very much. It's great to be with you all, and thank you, Stephen. So I'm going to talk you through now some of the key concepts of palliative care for people living with HIV from the new WHO consolidated guidelines. And we are absolutely delighted the WHO had the foresight to include palliative care as part of the essential healthcare package for people living with HIV. So thank you for including it, and thank you for asking us to present today. So there's a very clear message that palliative care is an essential component of HIV care. That's very clearly stated. It's an essential component of comprehensive clinical management for people living with HIV, as stated within the WHO consolidated guidelines. It's guideline 6.17. So looking at the evidence that we have for palliative care, there was a systematic review we published a number of years ago looking at the evidence for palliative and inpatient hospice care for people living with HIV. And the evidence was clear that for people living with HIV, palliative care can improve outcomes, including really important and highly prevalent problems such as pain and symptom control, anxiety, insight, so understanding of your disease and its likely progression, and also spiritual well-being. So this is a really important message that palliative care can make a difference for people living with HIV. In recent years, the evidence for integration of palliative care has been much clearer across diseases. And in fact, there are some large randomized control trials now, particularly in the field of cancer, showing that not only does palliative care save money and improve outcomes, but survival effect, that when you withdraw burdensome treatment and you focus on quality of life and a person-centered approach, you can improve survival. So let's have a look to see what people think in the poll. The question was, there is still a need for palliative care interventions in the current HIV treatment era. And I can see very clearly 96% see that, yes, palliative care is needed alongside HIV treatments. And that's good timing, because that's exactly where I'm going to take us now. There's a paper here that I've just shown you. Palliative care is an essential component of the HIV care continuum. And this paper in Lancet HIV is an overview of the evidence for aging, or the comorbidity and multimorbidity that Stephen alluded to, the higher incidence of organ failure, malignancies among people living with HIV, that mean, yes, we need treatment, absolutely, and alongside we need palliative care. So if we look at the next slide, what we're going to show you some evidence of what happens when you include palliative care within the health system. So here's some examples of data from Clint Cupido's integration of palliative care into Victoria Hospital in the Western Cape in South Africa. And when he included palliative care into his hospice service, and we did a comparative before and after study, we were able to show that the integration of a hospital-wide palliative care service reduced the number of people who had an admission, reduced the number of admissions, reduced the days admitted, the total admission days, had a cost-saving effect, and also increased rapidly the number of people who were able to meet their preference of dying at home. So palliative care can make a real difference. I'm really delighted that Liz Namakwai is with us today, who does fantastic work in Malago Hospital in Uganda. So I'm really glad to say that we have some clear guidance from WHO on what an essential package of HIV care looks like. And that's in the guidance for you to look at, the consolidated guidance. And I would urge you all to look at this free document, Integrating Palliative Care and Symptom Relief into Primary Healthcare, led by WHO with Eric Krakauer, building on the Lancet Commission, showing a very, very clear set of interventions needed as a core essential package for palliative care. So first of all, a list of safe, effective, inexpensive, including off-label, off-patent and widely available medicines, simple and inexpensive equipment, which may include things like drains, pressure beds, lockable drawers for opioids and storage, basic social supports, because of course serious and advanced illness in the family can lead to loss of income generating activities, loss of care functions in the family, loss of income to meet children's school fees, so it can have a family-wide and community-wide impact. And the human resources need to provide those medicines, the equipment and the social supports, and I'll talk a little bit more about that today. It's also important to think about what specifically might those needs look like, and I would draw your attention to this recent publication by Oladayo Falabi from Nigeria, who's looked at specifically what might a palliative care need look like in Africa. And there's some really specific evidence on what those social support needs, for example, might be. And I would urge other people in different parts of the world to do this kind of work, looking specifically at palliative care needs in your region. So it says very clearly in this document from the WHO on planning and implementing palliative care services, which is also referred to in the guidelines, that you need access to palliative care at all levels of healthcare systems and in the home. And it gives some very clear examples in more detail that we can share with you now. But for example, central level hospitals should have a palliative care team with at least one doctor who's a specialist in palliative care, nurses, social workers and psychologists. District hospitals need at least one doctor who is responsible for palliative care, nurses who are trained in the basics of palliative care, and a social worker. And healthcare providers can then support primary healthcare centres where you need at least one healthcare worker with minimum basic training who can assess, initiate and continue palliative care and supervise community health workers who the guidance tells us can, in a minimum of few hours, be recognised to train symptoms. And this is a very interesting debate, and there's some nice work by Fliss Murter looking at the role of palliative care clinicians, which is, of course, to provide a specialist service, but to mentor others and to support their colleagues who are non-specialists in providing palliative care for all. I would like to think also a little in this presentation about key populations. Of course, we think a lot about key populations in HIV, and this was specifically requested from us in the WHO consolidated guidelines when looking at palliative care and what that might mean for key populations. And I draw attention to some work by Jenny Hunt in Zimbabwe, who's looking at palliative care needs. And here's an example of a healthcare worker who says, if you're a female nurse and a sex worker comes as a patient, you would rather say, let her die because she's corrupting my husband and disturbing my marriage. So palliative care for key populations may be a challenge. And you'll see the title from this paper below. So isolation comes in, discrimination, and you find many people dying quietly without any family support in this study looking at palliative care for key populations, because of course family support to enable people to die in the community with minimum distress is absolutely crucial. And again, if we look at key populations, bereavement outcomes for LGBT people need consideration as well. And here's some modelling by Catherine Bristow that says actually your bereavement outcomes may be predicted to how well your same-sex relationship or your gender status and gender history are acknowledged and spoken and welcomed within your social network and your community. So there are some very specific considerations for key populations in accessing palliative care and getting bereavement support, which of course is part of palliative care. So I will stop there and then I will come back in a few moments to talk about measurement. So thank you.
Thank you very much for the opportunity to share our work. And I'm going to talk to you about our palliative care program in Kiridu and Mulago hospital sites. Next slide, please. Our palliative care is integrated in the care of patients who have life-limiting illnesses in the Kiridu and Mulago National Referral Hospitals, which are also teaching hospitals. And our model of care is such that basic palliative care needs are met by nurses and doctors who are not specialists in palliative care, but who have had training in palliative care as part of their curriculum or in service. And these refer on people who have complex holistic needs to the specialist team. And our specialist team offers consultative services across the hospital wards and manages these patients jointly with the primary care team. And the team is composed of nurses, doctors, social workers, and a team of volunteers. Next slide, please. When we are offering palliative care for patients, for people living with HIV, our goal is to prevent and relieve suffering, which is often multidimensional, and as a result, improve their quality of life, but in addition, improve quality of dying, improve the bereavement experience for their caregivers, enhance adherence to treatment, hence its effectiveness, and hopefully prolong life of some where it is possible. Next slide. Last year, where we received 117 patients to the specialist palliative care team. However, many more patients in these hospitals received generalist palliative care, and majority of the patients we received had cancer, and the main reasons for referral were for managing of complex symptoms and complex psychosocial issues, as well as support in communication and disclosure of HIV status. Next slide, please. HIV, like any life-limiting illness, threatens the integrity of a person, and they will have multidimensional suffering and multidimensional needs. The suffering will arise from the disease and the comorbid conditions that they experience, but also they will have psychosocial and spiritual distress. This suffering can happen at the time of diagnosis or any time through their disease trajectory, and it affects patients and their families. I'm just going to give some illustration of this among the patients we saw in the next case scenarios. Next slide, please. The first was a 65-year-old man who was recently diagnosed with pulmonary tuberculosis and HIV. His wife was found to be HIV negative, and though he was suffering with his physical symptoms of cough and difficulty in breathing, he had significant distress, psychosocial and existential distress, resulting from being blamed for infidelity, was isolated because the family feared that they would catch TB or HIV. And also he started wondering if he really had HIV, because he said the amount of weight loss he had was much more than he had seen in other HIV patients, and started thinking that probably this was witchcraft, and he had resorted to using herbs. Next slide, please. Next slide, please. The next case is a young man who had been on antiretroviral treatment for 2 years, was attending an HIV clinic in his home, and then got a job away from home, and it was a significant distance. He did not disclose to any of his family members or close people that he had HIV, and he had to travel back to pick his HIV drugs because he did not want to register in a nearby HIV clinic so that he couldn't be identified. And because of this, he failed in proper adherence. He developed opportunistic infections that led to acute kidney injury. And by the time he came, he had significant symptoms, multiple symptoms, but also there was a lot of family distress because his sister was a nurse who felt if she had known, she could have helped a lot. And lastly, a 65-year-old woman who had lived with HIV for more than 10 years and on ART for 10 years, then developed symptoms of cancer of the cervix. And when the diagnosis was confirmed, She had distress from her symptoms, which were isolating her because of the false mailing vaginal discharge. But in addition, she had severe psychosocial and existential distress, wondering why she had to have 2 life-limiting illnesses and why her and why God let this happen to her, being that she was a devout Christian. Next slide, please. So in assessment of patients who are living with HIV, we do a holistic assessment to try to understand these multidimensional needs and suffering. And we took a good history and do a detailed exam and investigations. The history is really to help us to understand the disease, but also we want to understand what drugs they've been on, the comorbidities they have, and also we want to understand the impact of the illness on their functional state. We use the ECOG. Next slide, please. And in our program, we have adopted the use of the APCA African Palliative Care Outcome Scale. This is a 10-item tool which has been validated for use in Africa, mainly for research, but for us, we use also it in our daily care. It has 7 questions that are for the patient. These explore the multidimensional needs of the patient, the physical, psychological, social, spiritual, but also the information needs, and also 3 questions for the caregiver. Next slide, please. So this tool, next slide, please. This tool helps us to screen for where most distress is, but we also do a detailed psychosocial and spiritual assessment, really to help us to understand what resources a patient may have that will help improve their quality of life. So for example, they may have good emotional and social support or good spiritual support from a faith community that we can use to help improve their quality of life, and also to identify those things that may be affecting their quality of life negatively, like facing stigma, and also faiths and beliefs which are maybe contrary to treatment. In our setting, mostly when some people have HIV, there's heightened spirituality, and sometimes they abandon treatment, believing for a cure. Next slide, please. These are some of the problems from our APCA pause analysis. Majority of the patients presented, over half of the patients had pain and other symptoms, and in majority of this, pain was severe. These were the ones referred to our unit, and yes, they send us the complex symptoms, and more than a third of all these had these other multidimensional problems. To note, all the caregivers reported that they were worried, and more than 80 reported that their degree of worry about their patients was severe. Next slide, please. On digging further into the symptoms and the physical problems, spiritual and psychological, we're able to get more symptoms that they had as listed there, and also to understand why they had worry, why they thought life was worthless, and also why they were lacking peace. And all these things listed here contributed to their state of, to their presentation. Next slide, please. This slide is just to show that when people are living with a life-limiting illness and HIV, what they present to us may be just the tip of the iceberg. They will present with pain, worry, maybe depression, poor adherence to drugs. And a good palliative care assessment should be able to unpack why these things are there. The deeper problems are the ones below the surface, and until we know them, we may not be able to offer good palliative care. Next slide, please. So our palliative care interventions, we develop a care plan, which includes meticulous medical management. This is usually done by the primary team on the ward, but also includes holistic management of the holistic issues they have. And in the care plan, it's important to involve the patient and the family, particularly in educating the patients about the disease and how to care for themselves, as well as educating the caregivers in patient care. And also ongoing support. Okay, in terms of physical care, we presented with based on
Just to check, Elizabeth, your connection might be oscillating and it's cutting for everyone. Apologies. Yeah, that will be helpful to cut the video. Thank you. Please go ahead and please mind the time.
Right, yeah. Yes, yes, next slide, please. So in addressing physical issues, we control symptoms based on symptom control guidelines, which I couldn't go in because of time. It's available for us in Uganda. We have the Uganda clinical guidelines, which contain these symptom control guidelines, but also there are so many resources, some of which have been included in what we have sent. Next slide, please. In terms of psychosocial support, we offer it by communicating and giving information, holding family meetings to make important decisions. And also we offer psychosocial support to the family and bereavement support to the family. We do a lot of linkage to other resources because we are poorly resourced. And so we link to the hospital social work department where there are social needs that we cannot meet, to psychologists, to legal services, and to several other services. Next slide, please. Most of our psychosocial and spiritual care is offered by a team of volunteers, and what they do mostly is to be present to the patient, to show them that they are valuable. Sometimes patients want to pray with them. They also link them to their religious neighbors if they want to, and also facilitate finding of meaning and purpose by asking them to tell their stories. And what we aim for is to facilitate healing of the patient and the family, even without cure. And as it's said by Tricross, that healing will mean saying, I forgive you, thank you, I love you. Next slide. Out of the 117 patients we treated, 90 were discharged in improved condition. A few of them were at end of life, but they preferred to be cared for at home. And 27, sorry, not 29, died in hospital. The map you see there, the yellow areas are the where palliative care services are in Uganda. This was given to us by the Palliative Care Association of Uganda. And we have contacts of this, and at discharge, we refer them for continuity of care to those areas. Thank you very much for listening to me. That's the end.
Yes, thank you very much. Listening to my country, my compatriot, Dr. Elizabeth, really was quite empowering. Made me relive some of the things I went through about 21 years ago. As you've been told, my name is Stephen, Dr. Stephen Watiti. I'm a clinician, but I'm also a person living with HIV. And 21 years ago, at the age of 47, I had advanced HIV disease. I was very sick. I had TB, MDR TB. I had cancer, sarcoma, and I had meningitis all at the same time. And I was not on air at that time. So I was in bad shape and dying, really. That's when I was referred for palliative care. Tell you the truth, the first thing my relatives thought was that this was meaning that I was going to die, and even me myself, because I knew this, the little I understood about palliative care then was that it was end of life care. And so I refused, and but thank God for a trained palliative care nurse who came and saw I was scared and offered to sit beside my bed and talk to me. Eventually, she convinced me to take morphine, and I did improve. At around the same time, they had also introduced me to ARVs, which at that time were very toxic medicines, which were increasing my symptoms. I developed a condition called lactic acidosis, which made me sick. I would literally vomit everything, including the drugs. But that said, this helped me, and I improved because of the palliative care. The pain was controlled. Eventually, the TB was treated, and now 21 years later, even what I feared most has not happened. I never developed a craving for morphine, which had helped me get on this. And because of that, I chose to be open about my status, something that Dr. Elizabeth has alluded to. Many people don't want to show that they have HIV and therefore need this. In my country, I was a bit lucky at that time that there was this fledgling palliative care department started by an expatriate lady, which helped me. But we still need a lot to be done, and this is why we need to do advocacy, especially voices of people like me who have had palliative care needs and are now living fairly good quality of life. My biology is suppressed and I am living well. Of course, now that I'm aging, now at 68, going 69, I know my palliative care needs are going to increase. And therefore, that's why I have decided to join the movement to advocate for availability. And I'm glad that WHO has recognized this, and even UNAIDS, I have been urging that we need to have a fourth 95, if I may say. There is the 95 people know their status, people treated, and people who are suppressing. The fourth one that measures the quality of life. This is something that I believe we need all to embrace. There is still a lot to be covered, because there is no universal coverage like in my country. Out of the 1.4 million people who have HIV, estimated to have HIV, about 200,000 are not on ARVs. And even those who are on ARVs, maybe not 95% are suppressing. And all these come up with palliative care needs because of the diseases that they come with. That is what I think, and especially as we look at the future of HIV and AIDS, in the future, most of the people who are going to have this disease are going to be older people. So we need to make sure that their needs, both spiritual and psychological, are met. And we need this. And therefore, in countries like mine, we need to train, especially palliative care nurses, specialists, and I call them specialists really. The palliative care nurses are special because they can offer the services that we need, that are needed. I thank you. That is my story, and possibly now we can have time for more questions and maybe more contributions. But I especially would encourage people living with HIV who may be on this call to especially weigh in with questions and possibly even more experiences. Thank you.
Thanks so much. Oh, sorry, please go ahead.
Yeah, no, I was just thanking Watiti. We'll just jump to Richard's last presentation, and also a reminder on minding of time, and then we will go back to questions and answers.
Great, thank you so much. So I've been asked to speak for a few minutes on measuring palliative care outcomes, and actually Liz has helped us beautifully with that. So what's an important outcome? Well, it's interesting when you look at death in the research literature in HIV, there's very little beyond did somebody die or not as a failure outcome. How people die or their problems during their death are very, very rarely researched. The lifetime prevalence of death for people living with HIV, as the rest of the population, is 100%. HIV testing and treatment is not going to reduce that. People living with HIV, just like everybody else, will still die at an appropriate point or earlier in their lifespan. So driving quality of HIV care, if we consider death as an outcome, a natural outcome which we want to try and manage, then measuring what matters is really important. An example of how we've tried to think differently about that in the UK, the British HIV Association is looking at deaths of people living with HIV in London. In 2016, we reported 206 deaths. A third of those were unexpected. So we've got a third of people living with HIV who died unexpectedly. And 61% of expected deaths were in hospital. And only 2/3 of the expected deaths had a documented prior end-of-life discussion. So we've been working with the clinicians to move from where this audit started, which is, are people dying and can we prevent their deaths, to thinking, are people dying, can we prevent their deaths, and also, can we better manage their deaths? So when we think about death in HIV, yes, we want to prevent it where possible, but we also want to manage it so that death is as painless and as distress-free as possible. And here's some data led by Joachim Cohen in the group, the iPod study in Brussels. I worked with him. We looked at death certification in 11 countries. There were nearly 20,000 HIV deaths recorded out of nearly 6 million deaths. Hospital death was by far the most common place of death for people living with HIV in all countries. And when we looked at the relative risk and age standardized data compared to cancer, people with HIV are less likely to die at home and more likely to die in hospital, which is not where people want to die. So you can have a simple outcome of where do you die. It's important. But what else matters to people living with HIV? Well, there's lots of literature in palliative care of what matters to somebody who is at the end of life. They want good pain and symptom control. Pain and symptoms are highly prevalent across conditions at the end of life. People want family support and a reduction in the burden on the family. They want their priorities and preferences listened to and accorded with. So where do you want to die? How do you want to die? What matters? They want a sense of resolution of their piece and getting time and support to prepare. And they want good coordinated, well-integrated, continuous care, not lots of fragmentation when you're frail at the end of life and you can't work out which healthcare provider is doing what. So very simple things we know that matters. If we can measure what matters to people at the end of life, then yes, it can inform research, so we can prove that we can improve end of life. Clinically, it can drive the assessment. If you ask people what matters and how it's burdening them, then yes, you can better manage it. And I think Liz Namakwai has just shown us beautifully in Uganda how they're doing that. And also you can audit death as well. So what are we managing well? What problems are we not managing rapidly enough? So if you've got use of outcome measures in clinical care, yes, you can do better assessment. You can monitor patients' changes over time and how to improve them. You can better communicate with patients and families, and you can make better decisions. And then also with your audits, you can get better standards and understand what you think should be the expected standard of care for somebody who is dying and is having their person-centered care needs met. And that's certainly what we've done with people living with HIV in the UK. We have standards of care signed up to by all the clinical colleges, working with people living with HIV and researchers and clinicians. We have the standards of care that should be asked for and delivered. And now palliative care is a standard of care which is auditable in the UK. You should be able to ask for it and you should get quality care. Liz talked about what we've been doing in sub-Saharan Africa. In fact, Stephen absolutely supported the very beginning of this work, where we firstly reviewed what we knew about palliative care in sub-Saharan Africa. We identified that HIV services were challenged by being able to measure what matters. Then we came together with multi-professional clinicians across sub-Saharan Africa to say, what should we measure and how? Then we developed the first African palliative care outcome scale, and then we validated it in almost 500 patients. And that's exactly the measure that Liz is using now. And then what we're hearing from clinicians that use that is that measuring the quality of palliative care provided was problematic without rigorously validated outcome measures that were suitable for use within the resource-constrained and culturally different African context. The palliative care outcome scale, it's free. I urge you to register and access it. We have over 12,000 users in 120 countries. just driving clinical care, helping us holistically assess patients and to conduct research and audit. So now in South Africa, for example, it's embedded into the public health system to improve practice audit training, resource allocation and research. Even Misango and the African Palliative Care Association developed the world's first outcome measure for children. We're now catching up and trying to replicate that work in Europe. And we've also been developing hand scoring measures for people with low literacy so that they can report their symptoms, their concerns and their distress if they struggle with a numeric measure, and they can use their hand to score. So this work is really doing exciting things. The African Palliative Care Association has guidelines on how to use it. The Hospice Palliative Care Association of South Africa has guidance on how to use it for clinical audit. It underpins the standards for hospices in South Africa, and it's also measurement of outcomes is a quality standard right across sub-Saharan Africa for palliative care. If you measure people living with HIV symptoms and concerns, which we did here for the US government, we measured what matters using a palliative care outcome scale in HIV clinics in East Africa. We were then able to develop a simple intervention for people living with HIV, where we trained ART nurses on how to do palliative care, what it involves, how to assess. It was only 2 weeks of training, that's all it was, on palliative care for HIV. And we're able to show in Mombasa that if you train people in palliative care in a randomized controlled trial, you can improve mental health, psychiatric morbidity, and palliative psychosocial problems among people living with HIV, and really deliver what we consider to be person-centered holistic care. So lastly, going forward, we've just completed this work for the WHO, taking the POS, the palliative care outcome scale I showed you, putting it on an app in India, Uganda, and Zimbabwe. This has really revolutionized community health workers' ability to assess patients in the community, and clinicians loved it because what they were getting on a dashboard was patient-reported outcome measures live. They could see which patients had the worst pain, the worst distress, the worst symptoms, and they could allocate their scarce resources and their staff now to those patients that needed them, because they had live, to the moment, information on what mattered to their patients. So the future, I think, is taking outcome measures into mHealth. So thank you very much. Those are my few minutes on outcome measures.
So now perhaps I request Stephen to go back to the Q&A now. So I think we can begin. I think we've concluded all of our presentations. So the floor is open. And Stephen, I think we have some questions here that perhaps you've already seen. So I'll leave it there. Thanks.
Yeah, I think live. The issue about let me see, about pain management. Many people associate the two very closely. Many issues of quality of people living with HIV, stigma, mental health.
Stephen, we are losing you. Oh yeah, can you try again?
Without a bit, where's the Q&A? Okay.
Yeah, I can read it out for you, Stephen. I think that's okay.
Yeah,
so the first question, yeah, no problem. So the first question was from Todd Pollack. Although palliative care is not only about pain management, many people associate the two very closely. Many issues of quality of life in people living with HIV today are more related to stigma, internalized and experienced, and mental health than physical pain. Can the panelists comment how palliative care approaches can best be expanded to address these issues of quality of life?
Yeah, I think one of the things that I alluded to is the issue of focusing on the person other than focusing on the disease. You see, the main problem is that with the zeal of wanting to look for all people living with HIV, we set up these 90 targets, which eventually have turned into 95 and 95. And when we get them, we tick the boxes, but we forget that the person who has suppressed may be depressed at the same time. That's a mental problem. Or may not have comprehensive knowledge, like you saw the slide that Elizabeth showed. What they show, the symptoms, are actually the tip of the iceberg. Many of these are having challenges, people are having pain is pain, whether physical or emotional. So we need, I think, to have a more holistic way of looking at the person other than just focusing on the physical. Because physical is indeed true and it's mainly what they complain of. But how do you help somebody who has lost a job or who is not able to live comfortably at home because of stigma associated with this disease? I think that's what we need to do to ensure that people living with HIV are empowered with knowledge. Look at me, although I was a doctor, I was very, very disempowered because I never had comprehensive knowledge of the disease and even of palliative care. That's what I would say. And maybe somebody else can weigh in, of my colleagues, I know they are my namesake, Stephen, or
the other Stephen. Yeah, I think this is a great question. We did see Liz's slide on total pain, which I think is a good indication, which is one of Cicely Saunders' great contributions to the field, that pain is in all four of the quadrants of experience: the physical, psychological, social, and spiritual. And doing these sort of impeccable assessments with people, doing really person-centered assessment is critical to understanding the person's experience and where their suffering is, and addressing it appropriately, if it's to do with the relations with other people, if it's to do with your sense of self and well-being, or if it's literally if it's a physical pain, which about half of people with HIV are going to likely experience moderate to severe pain. But it isn't the most pronounced. I agree with the questioner that some of these mental health concerns can be equally or more important, and that's why palliative care is helpful, because we really tailor the approach to the person's life experience and needs. They're the ones directing the care, not us. Richard or anyone else want to comment on this? Or Liz?
Yeah, I think the crucial thing here is understanding of pain and what pain is. So of course, if somebody has that kind of social rejection and stigma, of course that is painful. And you can measure pain, but when you do an assessment, you understand where people's burden is, but then it's that detailed unpicking of what's causing it. The greatest example for this always is, for me, a Portuguese colleague talking about a woman with advanced cervical cancer screaming out in pain for a prolonged period of time, and they were titrating her opioids and unable to stop the pain. And it wasn't until a palliative care nurse spent some time with her. The cause of her pain was her facing her impending death and leaving her children motherless. That's what was causing her pain. And it wasn't until there was that detailed discussion and that person-centered assessment that they understood that's what it was. So that woman needed counselling and mental health support.
And maybe perhaps quickly to say, I think as far as, from, the WHO guidelines perspective, I think this was a discussion that we had, many times, in that we really need to bring the cause of palliative care quite central into general care for people living with HIV. I think this was one of the many conversations that, I think we had with Stephen and Richard as well, leading up, to the launch of the guidelines. And I think it's really, I think we're also, hopefully, we've sent a sufficiently strong message to say that this should really be central to HIV care, because it is one of the components that actively promote people-centered care. And I think that message of, focus on the person and not the disease is a much better way of saying people-centered care. And I think that's, I think that's really great. But yeah, that's it for me.
We'll go on to the next question.
Yep.
Go ahead.
Perhaps I can read out the next question quickly.
Yes, please.
Sure. So this is from Antonia Kamate Tukundane. We have been celebrating the Year of the Nurse. Is it possible for WHO to spearhead a similar advocacy drive for palliative care nursing? This would give us a boost as nurses working in palliative care. There are also other healthcare providers who have selflessly provided palliative care, but their professions are not commonly known globally, and there are some specific to Africa. For example, orthopedic clinical officers, physiotherapists, and occupational therapists, etc.
That seems to be for WHO, I guess.
For Richard.
Yeah, well, what I can say is I think this is very important feedback that I can take back to my colleagues at palliative care and we can discuss. So we appreciate the suggestion. I think including this into our guidelines, I think was a vital first step. But I think we can definitely work to broaden this in the context of people living with HIV and palliative care.
Yeah, I mean, I would add to that, AJ, that my observation is wherever I go in the world, palliative care is often nurse-led. It's the nurses that have the relationships with the patients and have the continuity of the care, following them into the community. And of course, one of the greatest things that's happened, and Uganda was definitely at the forefront of this, Liz, was the ability for nurses to prescribe opioids. And I think that's a really important step forward for palliative care nurses, because if nurses are unable to prescribe opioids, then that's a real challenge to pain management. So I utterly agree. I think we need to champion the nurse in palliative care.
But I think also we need to do advocacy at country level. In my country, yes, there is that step, but when you go to hiring them, you will find that they are trained, but many of them are not on the list of people to be hired by government facilities. I think we need to do more advocacy, because there is no way we are going to have doctors enough to offer this palliative care, and yet they can do a good job, like we have seen, at least experienced myself.
Yeah, and I think one of the ways it's trying to be done in Uganda is to have a policy on palliative care, so that there will be specialist positions for nurses that are recognized in the structure of health professionals in the hospitals, and maybe that will help. And maybe WHO also can be an advocate at that level, at the government level, and probably that's what Antonia would also want to see.
Yeah, certainly a policy would go a long way, but of course policies must be put in practice. I think this is where we need to go and make sure that these policies are put in practice. But certainly a policy would be a great beginning. Yeah. I don't know whether there are any questions, Ajay, if you could read.
So we have a few more questions. I think we can maybe do 2 more live questions. I think we have enough. There was a second part question from Todd Pollack, which is about how can we better engage community groups in the provision of palliative care? For example, key population-led care or peer support programs.
Well, I think we do have a new model now for palliative care development that just was released. It had been a public health model which involved policy change, medicine availability, and education. But we've added to that model empowered communities and individuals and research. And palliative care was always it started as a community-led response to the need, and volunteer groups and in the early days were the ones starting it, including for HIV. And we've seen governments step up in some countries, not all countries. We still, we are a movement because it's something that the community is responding to, and governments sort of catch up later. But how to encourage that? I think we've seen a movement for compassionate community development. And I think it parallels very nicely to palliative care development. And I'd encourage people to take a look at how compassionate communities are formed. Other comments from panelists?
I mean, I would say the other interesting thing, Stephen, is the revisiting of palliative care amongst communities of people living with HIV. Because you're absolutely right. If you go back to the late 80s, early 90s, it's what we were all doing. It's community groups supporting each other. People were dying. It was horrific. And there was lots of stigma. And people just supported each other from the community up. The wonderful advent of treatment meant we'd stop thinking about death, and that really wasn't on the agenda for our conversations. And now people living with HIV are aging, and they're starting to think about their aging and what they want, which is fantastic. So my experience of working with community the last 5 years really has been really different and really positive, and people standing up and speaking at conferences and meetings on behalf, saying, I live with HIV, I want palliative care, much as Stephen did so eloquently for us today. And that's a very, very important message, saying, actually, at some point I will die like everybody else in this room, and I want to die well.
I think that's very important. But of course, in my country and like many other countries, most people living with HIV are not open, and we don't expect them to be open. But I think they are part of the community. We all need to be involved in making sure there's palliative care in our community, and that it is quality care, really. I look at it like a parachute. Of course, most parachutes are never used, but if when you need it, you don't have it, you don't need it. Tell you the truth, if I didn't have palliative care 21 years ago, I don't think I would have managed to go through the very rough patch of life that I went through. But again, as you have mentioned, Richard, is that all of us are going to age, and as we all shall die eventually of something. So we would like to die with dignity. We would like to die with dignity. So I would invite every person, everyone, other than people living with HIV, but all people. And as I've mentioned, the majority of people living with HIV in my country and many other countries are not open. So we should all be involved in this, that it should be part and parcel of comprehensive care. We can't talk about universal health coverage unless it has all the components, which includes palliative care. Thank you.
Thanks, Stephen. I definitely agree with this also, because I think when we talk about, HIV and aging with HIV, I think we're also talking about the, increasing burden of non-communicable diseases as well. And I think that also is an important component to ensuring quality of life, managing non-communicable diseases such as cardiovascular disease, hypertension or diabetes is such a vital component, because these diseases can, if not treated well, cause immense suffering to the individual who has, these diseases, because it's perhaps it's more insidious or more indolent than, say, an infection, any new bacterial infection or something like that. But it can definitely cause a lot of pain to individuals if we're not applying this broad focus of quality of life, for people receiving ART over their life course.
Well, in the early days of the pandemic, it was really a focus on getting people treatment, getting ARV treatment. Now that we've done such a good job with ARV access, it's time to advocate for people with HIV, to advocate for better care, it seems to me.
So next, quickly, I would like to call upon Martin Chu, who had a question for our panelists.
Hi, thanks WHO for organizing this, and Bruce's team. My question is, when we say person-centered care, and we say that we're assessing the needs of a person, obviously the context of the person is important, but we don't really understand what the process of this assessment consists. And what, it's one thing to say that there are standards of care. It's another thing to say how these standards are measured, how are they concorded with experiences on the ground. So I think WHO could hopefully, and academics and clinicians could help us to bridge the gap. Thanks very much. Love to hear your thoughts on this. Thank you.
Thank you, Jamie. Stephen, do you want to comment first? Stephen Watiti?
Stephen,
He may be not connecting very well. Richard, do you have a comment?
yeah, I mean, it's a really important point, isn't it? You know, you've got to enable people to ask for what they need and for it to be available, but there's, the risk of a mismatch is enormous. So, I mean, I think one of the first things that's happened, which is kind of the watershed moment in the last few years, is the inclusion of palliative care as an essential health service. And there's a couple of important messages, aren't there? Is that, yes, this should be seen as an essential health service and must be provided within your health system. And your health system has to see the value of it, because, of course, what we know is that palliative care improves outcomes for patients. It maintains them at home, because one of the biggest drains on health resources is people in the last year of life. In the US, it's estimated anywhere around 20% of healthcare budget is spent on people in the last year of life, because what you have is lots and lots of unplanned admissions, lots of coming in through A&E into wards when they should be maintained at home. So actually it's good for the health system to keep people at home, not accessing inappropriate treatment, but well managed and having their distress controlled. It's cost saving and it's better for everybody. So there's some advocacy work there to be done to make sure that health services understand that. And it comes down to education as well, doesn't it? Because one of the questions needs to be in your country, within my curricula and training programs, how much time is spent on palliative care? Because a lot of what we do, amazingly, is not complicated. If you can give people the communication and assessment skills to ask the right questions and to understand very basically how you can control the most common symptoms, you can make a difference quite cheaply. So those would be my comments.
Yeah, I agree entirely around the education need. We think that as many as 2/3 of palliative care patients could be cared for by their primary care providers if they were trained in palliative care, if they had adequate, even basic training. So, I mean, we're in a situation where, you know, the vast majority of current healthcare providers don't have any training at all in palliative care, and it's been a bit of a struggle. And it's also, you know, quite important for people treating those living with HIV to have that same skill set. Would make a huge difference because the quality of those assessments are, from a standards perspective, Jamie, I mean, there is a qualitative difference many times in whether you're really getting a multi-dimensional, interdisciplinary, multi-system assessment versus just, you know, some sort of cursory examination. Yeah.
I think I also would like to say, in countries, low-income countries like my country, where we have seen palliative care nurses do a great job, I think we need to make sure that all training schools include palliative care in their curriculum, other than having this type of specialized nurses. Every nurse, every healthcare provider should have some comprehensive knowledge of palliative care, being able to at least identify the palliative care needs of a prolonged pain, like we have already alluded to. Thank you.
Yeah, that's a very important point, because most of the palliative care needs people living with HIV will be needs that can be met by people who just have generalist skills, not necessarily specialists. So having with a critical mass of people trained, I mean, everyone trained will go a long way to improve quality of life.
Yeah, I think one of the important takeaways from this is that really any person in the healthcare hierarchy really can receive training for palliative care and can offer it, because it's really a question of looking at the person. Like, you know, I think that's a really strong point that has come out, you know, through this panel, which is sort of focus on the person. I really think just a basic understanding of why it's important to provide palliative care and understanding the key components itself will allow for healthcare providers to apply a more comprehensive approach to HIV care. We had one more question, and unfortunately, I think there was a typo and there's a fragment of a sentence, but it's still, I think it's a valid question. I think this question was for Stephen Watiti, which is, in his experience, like what would be the approach of palliative care in patients with depression and terminal illnesses? So I'm guessing the lens through which we will look at this is for, among people living with HIV. Thanks.
Yeah, I think that's quite important. Some study is done here. I think I remember a study where it was done at the hospital I was working, and they found that 35% of the patients were actually depressed. But people were, because they didn't know how people didn't recognize, they thought these were just part and parcel of stigma. But these were clear people who were depressed. They only realized that these people were not taking their medicine well when the viral load went up. But this depression could have been picked earlier. So I think, of course, there is also the issue of stigma associated with mental illness, but we need to find a way of looking at people beyond, as we have already said, suppressing their viral load, but also the issue of demand creation for these services, because it's one thing having the services, but people refusing to use them. I've seen, for example, people with terminal illnesses referred for very expensive treatments abroad and paid for by government in Uganda here. And I think this is something, mainly because these people use their way there, because they don't want palliative care, and they go and get treatment which is not very helpful but very expensive for all of us. So I think demand creation, but also the importance of healthcare givers being able to identify signs of depression, signs of mental illness, which may be subtle, and being able to refer them in a timely manner. That's what I would say, but I guess my colleagues may be able to add on, especially Richard, who is seen more patients in this area.
Well, before Richard, I might just make a note as a clinical psychologist myself that the question was about could lay people be involved in the treatment of patients because of the lack of access to psychiatric services, and we do have some good examples of training programs where we can teach lay people basic interventions around depression management that in India that have been tested that have shown to be somewhat successful. Richard, do you have any other comments?
Yeah, I mean, the great learning from Africa, of course, is Dixon Chibanda's work in Zimbabwe on the friendship bench. I mean, it's just revolutionized and taken the whole world's attention, where he takes grandmothers and lay people, trains them in basic mental health care. And there are friendship benches out and about in Zimbabwe. If somebody needs support, they sit on the bench with one of these trained mental health caregivers, and trials show it works. It's just fantastic what Dixon's done. And in fact, Chibanda also works with Island Hospice in Zimbabwe, so he's a friend of palliative care as well.
Wow.
I think maybe do Stephen or Elizabeth have any final comments?
Yeah, I would like to say it is important that we take advantage of, especially people living with HIV, because these are the best. They are the ones who come for the appointments and maybe do a lot of education on the importance of palliative care and why it shouldn't be stigmatized, and find out where they go for these services. There is something like that, because it is a question of time, whether through old age or some other event that you need this service. So I think health education, treatment literacy, health literacy are very, very important. And this will go a long way in creating demand, but also advocacy for these services to be provided. Thank you.
Thanks. And Elizabeth?
Yes, also increasing access in the community. We could use, for example, in Uganda, we have village health teams. These are usually people, lay people who are trained in basic healthcare. They can be a very good resource in educating the community about palliative care and stigma, how to reduce stigma, and also use people, opinion leaders that the community listens to, like leaders of churches and faiths who will, if they speak against some of these things that are happening, like stigma, that will go a long way to help with these problems.
Thanks. Perhaps I can move to wrapping up now. I think we've, we can conclude our Q&A session as well as the entire webinar, sadly. So I just thought I'd put together a few bullet points just to kind of run through some of the things that we discussed today, and I hope that you found the webinar, educative and useful. So I think, needless to say, I think it's very important to think about applying palliative care throughout the life course in people living with HIV. Our poll really showed that, our audience today is very aware of its importance and also place for people living with HIV. It's important to really look at healing both the patient as well as the family. And it is possible to implement a system of palliative care into hospitals, and educating the health workforce is a really important first step, and it doesn't take that long to do so. And also we need to start thinking better about what are the kind of outcomes that we need to be assessing in terms of measuring palliative care in hospitals and how it's actually improving lives, and that we also have a demonstration that it can improve outcomes at hospitals by reducing the duration of hospitalizations as well. So I think, I think there are clear approaches that can be applied broadly into LMIC settings as well. We have, a really good country example to show that. And also that, when we talk about training, really, it can help improve, mental health outcomes. It can improve psychiatric morbidity. It can also help solve a lot of palliative care issues as well. And again, I think an important point raised from our audience is that really we need to be working to tie the standards that, our evidence helps us set to what happens on the ground. And I have to conclude by quoting what was said earlier, saying, focus on the person, not the disease, and ties into the people-centered care. So I think with that, I'd like to thank our wonderful panelists, the really great ECHO team, and of course, all of the audience today. Thanks so much.
Be sure to read the section on palliative care in the consolidated guidelines.
Exactly. That's the aim. Thank you, everyone.
Thank you so much to WHO. Thank you.
Yeah, thank you, WHO. Bye.